Good morning, everyone, and welcome to our Understanding Procurement Corruption Risks in the Health Sector session as part of HSR. I'd like to thank HSR for hosting this session and for everyone who has joined us this morning. I'm sure you're going to hear this a lot throughout the week, but when we initially planned this session, we thought we'd all be joining one another in Dubai and being able to do this together. Unfortunately, we're now having to do it remotely. And this means that the session's obviously going to change slightly in the structure. Before, there was going to be a lot more of hands-on, one-on-one tutoring type activities in order to fulfill the skills building. Now there'll be more of a broad introduction to the topics that we're going to talk about, and then move on to some what you would probably traditionally call skills building later on. So just before we get too much into it, just on the platform that you should be able to see, you can see at the top there's a support chat, which will help you be able to help you actually using the platform. Below that, there is a Q&A part, where the way that we're going to do Q&A is the session is split into 4 parts. We'll take specific questions about one of the sections at the end of each section, and then we have time for a broader Q&A at the end of the full session. And then you can see a couple of other key tips, I guess, on using the session there. Okay, if we move on now. So as I said, this is the Understanding Procurement Corruption Risks in the Health Sector. It's going to be myself and my 2 colleagues, Jonathan and Tom, who are also from Transparency International. I'm the senior officer doing MEL, part of the Global Health Initiative. Go next.
Hi, very good morning, everybody, and welcome. My name is Jonathan Cushing. I'm the head of programs at Transparency International's Health Initiative. And also with us today is Tom Wright.
Hello, everyone. My name is Tom Wright. I'm the Senior Research and Advocacy Officer working on the procurement issues with the Global Health Initiative, Transparency International.
Okay, so onto the structure. As I said, this is going to be focusing on procurement risks in the health sector. Again, like I said, when we planned this session, we're going to be face-to-face. That's no longer able to happen, but I think that since we wrote this session, it's become a lot clearer to a lot of people some of the importance of procurement in the health sector due to the response globally to the COVID-19 pandemic. So the way that we're going to structure this session is we're going to give you a brief introduction to Transparency International and the Health Initiative, followed by corruption in health and open contracting, which is a pre-recording of a lecture giving you an introduction broadly to the topics of health and open corruption in health and open corruption. We'll then have a short 5-minute break, and then we'll move on to a more practical side where Tom will take you through how to use data to monitor procurements. Before finally we have a summary and Q&A. So next. John, do you want to give an introduction to Transparency International?
Sure. Thanks, John. So for those of you who don't know, Transparency International is a global movement that has the vision of one world, or a world free of corruption. We work in about 100 countries worldwide through a chapter network. And we at the Health Initiative are the kind of technical team, if you like, who work with chapters around the world to try and ensure that corruption in health is stamped out, and that in doing so, we get more efficient, more accountable health systems in countries. In doing so, we hope to achieve SDG 16, which is anti-corruption, and also SDG 3, which I'm sure, as all of you know, is health, and contribute to the achievement of universal health coverage. Our work has got kind of three main strands. We work across open health procurement, so improving procurement transparency, as Sean mentioned, anti-corruption in service delivery, and that is looking at the impacts of corruption on the end user, so from petty corruption and the impacts there, and then also transparency in medical research and research and development, so looking at the effects that opaqueness has in the development of new drugs, and also the kind of transparency around the research overall. Currently, we work, as we'll be explaining later today, on the Open Contracting for Health project. This is a program that we've been working on for the last 3 years in 5 countries, mainly in sub-Saharan Africa, so South Africa, Zambia, Uganda, Kenya, and also in Nepal. The aim of this is to really open up procurement in the health sector, to start kind of unpacking that black box of procurement. So we work alongside others in the sector and use an approach called open contracting, which very simply gives everybody access to the procurement data and the information in the procurement cycle, so that an interested user, of which I guess many of you will be, can see what's going on. So from the tender documents to who's been awarded the tender, they can get all the information out of it. What that means is that, theoretically at least, that reduces the opportunities for corruption, because everybody can see if the tender's been awarded perhaps in a favourable manner to, let's say, the best mate of somebody in the procurement department. That becomes immediately obvious. It should also increase efficiency as well, that if everybody knows what the cost of what people are bidding, they can see where there is market collusion going on, or if there's potentially monopoly in one sector, and also allows others to enter the market because they can see how they can bid, or what they should be bidding on, what sort of price they should be setting. So theoretically, it also allows for economies to open up and more SMEs to come in. Based on this, and over the last, well, not quite a year, but since March, we've been looking at procurement in COVID-19. So using this data in 7 countries, which is a mix of countries. So it's the UK, Kenya, Kyrgyzstan, Mexico, Chile, Moldova, Ukraine, to look at the COVID response and look at what countries have been doing, so monitoring the response there to increase equitable access and make sure that make sure that the COVID response is done in an equitable manner. This has kind of been much more reactionary in many ways. And for those of you in the UK, such as we are, you may have seen some of the kind of concerns shared there around direct awards of tenders, procurements that have gone missing or have been substandard, and that's not just limited to the UK. There have been similar cases kind of across the board. We're using that to then engage in policy dialogue, but also with governments and also at the global level, but also to try and strengthen and shape the procurement response for future pandemics. So it's ensure that that doesn't happen again and that countries are better prepared. Finally, working with 100 chapters across the globe, we maintain a resource base and a knowledge base called HealthWorks, which details best practice ideas and collections for those that are interested, both within the Transparency International movement, but also elsewhere, so CSOs or governments or researchers, to better understand and better identify how they can address corruption in their own sectors. It's our own countries. Next slide, please.
Hello, and welcome to this presentation on corruption and health procurement. My name is Tom Wright. I'm the Senior Research and Advocacy Officer at the Transparency International Health Initiative. I work specifically on a project called Open Contracting for Health, which we'll go into a bit more detail about later. I'm recording this from my study in central London, so apologies if you can hear cranes or cars in the background, or just don't enjoy the British accent that much. During this recording, I'll be touching briefly on the scale and the effects of corruption in health procurement, and then concentrate mostly on how anti-corruption in this area works in reality. So both in what we do at TI, or Transparency International, and what is generally seen as good practice. Just before we start, however, it's important to note that my work concentrates mostly on low to middle income countries. And while much of this presentation is generalizable to different countries, different country contexts will obviously require different types of approaches.
The Open Contracting for Health Oc4h initiative is a UK-aid Department of International Development DFID funded project which aims to facilitate the adoption of systematic publishing and usage of health procurement data in 5 countries across Africa and South Asia. In Uganda, the project area covers the districts of Soroti, Lira, Bulisa, Mubende and Masaka.
So in the past, we were looking at contracts which were being done. We were looking at physical side of those things only. But we had forgotten about the process and procedure of contracting, which is now what we are starting at.
The Oc4h outcome for this sector is increasing sustainable engagement in civil society in public procurement processes through network strengthening and capacity building.
Those contracts is a process. They taught us that it is a process. When procurement begins, there is advertisement, there is competing, there is bidding, there is opening the bids, and all that, signing the contract. Those systems should be monitored also.
Transparency International has trained civil society organizations on how procurement processes are conducted, developed monitoring tools to act as guides for them in their monitoring process, developed an e-learning platform to further build their capacity on how procurement processes are conducted and how to monitor them.
The monitoring tool introduced by Transparency International helps us to identify the red flags throughout the procurement process.
And it has not been easy before TIU came, because the contractors themselves would not give these documents out. And the authorities on the ground let's talk about the sub-county authorities, they would not even bother to know what the contracts are all about, or the BOQ, or the agreements for the contract.
For community monitors, we would acquire contracts for health center 2s being upgraded to health center 3s and make simplified versions so that they can monitor by making comparisons between what is being constructed vis-a-vis what is in the contract.
We have been trying to see that the things which were taught in the BOQ, they follow up exactly what is in the BOQ. For example, when we started following up the construction of the building, the materials sometimes were not up to the standard. We tried to advise our contractors who were building our structure. They changed those blocks to a grade 1.
At first, the community was very far, could not come nearer these people when they are building. They thought that it is their own work. But this is now, after getting the knowledge, everybody is now free to come and check what is happening in the community and we own the work from the government.
We've been empowered to the extent that we can also reach the district leaders, officials, to inquire information from them with the help of the monitoring tools that has the guiding questions about how much information we can get.
So we've had a slight technical hitch. That was not the intended video. That was meant to come later in the session. But I think now, apologies for that, we should be able to launch the correct video.
Hello and welcome to this presentation on corruption and health procurement. My name's Tom Wright. I'm the Senior Research and Advocacy Officer at the Transparency International Health Initiative. I work specifically on a project called open contracting for health, which we'll go into a bit more detail about later. I'm recording this from my study in central London, so apologies if you can hear cranes or cars in the background, or just don't enjoy the British accent that much. During this recording, I'll be touching briefly on the scale and the effects of corruption in health procurement, and then concentrate mostly on how anti-corruption in this area works in reality. So both in what we do at TI, or Transparency International, and what is generally seen as good practice. Just before we start, however, it's important to note that my work concentrates mostly on low to middle income countries, and while much of this presentation is generalizable to different countries, different country contexts will obviously require different types of approaches. So the Transparency International Health Initiative is a global initiative where we aim to improve global health and healthcare outcomes by reducing corruption and promoting transparency, integrity, and accountability within the health sector. So how do we do this? We do this mostly through two approaches. One, advocacy, raising awareness and promoting the benefits of transparency. And two, through project work, where we work with our in-country offices. Transparency International has offices, or as we call them, chapters, in over 150 countries around the world.
So, what do I want us to achieve in this webinar? We have three main objectives. The first is to explain why procurement has one of the highest risks of corruption in the health sector, and also go into what effect that has on the health system as a whole. We want to talk about how to tackle corruption in health procurement, and through this, we're going to define what open contracting is and explain how it is used in different country contexts. Finally, we're going to go into detail about social accountability and how this works in relation to health procurement and open contracting. Social accountability is what we've been doing in the open contracting for health project mostly, and this is where you'll be finding more examples from our work.
So outside of the health sector, talking about procurement in general, procurement accounts for around 50% of government's total expenditure in low to middle income countries, and around $13 trillion globally per year, which if stacked in dollar bills would reach from the earth to the moon and back. And given these vast sums of money, it's not surprising that procurement in general is seen as one of the greatest corruption risks for government.
So why is it that health procurement is so susceptible to corruption? In general terms, it can be argued that this is because of its technically complex and lucrative nature. Because it's lucrative, there is more profit to be gained from corrupt acts, meaning there is more incentive to commit them. Because it is technically complex, it means that the process is fully understood by only a select group of people, meaning that first, only a few people can properly assess every aspect of a procurement to ensure that there is no corruption. And second, those that understand its complexities well enough are likely part of the buying process itself, meaning that they can subvert the system and commit corrupt acts with less of a chance of being caught. Essentially, potential corruptors have a higher level of discretion, and given the amount of money involved, a chance of a higher reward.
In every country I've worked in, there are huge amounts of examples of corruption in healthcare procurement. Almost everyone I've spoken to knows of one or two of these and agree that it's a huge issue. This is particularly true in the current COVID-related context, where emergency procurements are becoming the norm, and we're seeing a rush for supplies like PPE. that all go through the procurement system. These are just 3 particular examples pulled out from 2016, but you will find more examples from every country in almost any year that you search. So what effect does corruption in health procurement have on the health system? Whether a particular procurement is for a service or for delivery of goods, the subsequent implementation of this procurement can be seen as a resource that is used and needed by the health system. What we can say with certainty is that corruption in health procurement reduces the value of these resources through degraded quality or quantity or both. This can be through acts such as direct embezzlement, i.e. the pilfering of drugs, or through corrupt decision-making, e.g. if a bribe is accepted to give a particular contract to a particular supplier, even if their products will be of worse quality or of less quantity. As seen by this slide, this is particularly prominent in medicines and in health equipment procurement. Essentially, corruption removes critical resources, meaning that governments either have to spend more to make up the gap, and means potential underspending in other critical areas, or let those in need go without. Just to labour the points, as is shown at the bottom of the slide, corruption in health procurement is related to 6 out of the 10 main reasons that the WHO gave the statement, and 20 to 40% of healthcare financing does little to improve the health of everyday people. When looking at aggregate effects of corruption, it's easy to overlook the impact this has on individuals, but immediate consequences on patients are clear. They may not be able to access medicines or medical devices at all, or buy falsified, degraded, expired, inferior, or inappropriate medicines from private sources, leading to further declines in public health and inability to work, permanent disability, or death. There are articles available that I can share on this. So what can we do about corruption in healthcare procurement? So at TI, we've been working on something called open contracting. And the way I define open contracting is it's essentially a modern brand for transparency in procurement. It's essentially a term for a suite of different approaches for improving accountability in procurement and thereby reducing corruption. And in the case of the TI Health Initiative, we're applying this to the health sector. I refer to it as a suite of approaches because not all will be appropriate to all contexts, and instead anti-corruption implementers must use their expert knowledge to choose the right approaches for the right contexts. Open contracting includes both modern approaches, such as big data, e-procurement, red flagging and analytics, as well as more traditional approaches, such as physical contract monitoring, community scoring and discussion. At the bottom of the slide is a link for an overview of all the different approaches available. The key to successful design of an open contracting project is not only to choose the right approaches, but also to link approaches together. For example, choosing which contracts to physically monitor becomes easier if data analysis flags specific procurements, while analytics and data dashboards become less techy and abstract if backed up with real-world stories and experiences. Our project Open Contracting for Health has been designed to try and strike this balance while choosing the right approaches for the right context. We'll go into the different approaches in a bit more detail in the subsequent slides. So the Open Contracting for Health project is a multi-country project working in 5 countries, 4 in sub-Saharan Africa and in Nepal. We seek to test approaches to procurement transparency under the brand of open contracting in these different countries. And in general, we've found that more traditional approaches or more social accountability focused approaches in these countries has worked better because of the lack of data infrastructure. Most of the rest of the presentation will be talking more about these social accountability approaches because it's where we found we've had the most impact. But that doesn't mean that data approaches haven't been effective. And they certainly have been when combined with more social accountability approaches. I won't talk about that in this presentation, but if you're interested in how to combine these approaches, please do drop me an email.
So, social accountability for open contracting for health projects has been identified by us as the best way to achieve anti-corruption impact in health procurement in our specific countries. Social accountability, as can be seen from the definition here, is essentially the process of empowering communities to hold government to account. Specifically in health procurement, it can do things like monitor the amount or quality of goods going to a hospital. You can monitor infrastructure of hospitals, for example, to make sure that they're up to scratch and don't degrade quicker than they should. There are many ways in which social accountability can be implemented, many tools and approaches. And in the next few slides, I'll break it down a little bit to show how exactly they work and the effect they can have on corruption in procurement. So these are two examples of approaches you can take to achieve social accountability and therefore reduce corruption in health procurement. The two I've picked here are participatory planning and community scorecards. Participatory planning is essentially getting the community involved in the planning stage of a procurement. So when it's being decided what goods are going where. So this can be at a local level, this can be at a national level, but in terms, for example, at the local level, it could materialize in the form of community meetings with procurement officers, or it could be communities using previous analysis of procurements in local newspapers, for example, to try and address gaps that they've identified in previous procurement processes. For community scorecards, this is a tool that where communities score different services and goods based on a scorecard. So in a simple graph, they'll have certain categories in which they can rank these procurements, these goods, these services. In terms of healthcare procurement, it might be asking visitors to a health centre whether there were stockouts of essential drugs, which there shouldn't be, or even things like absenteeism. There are a huge amount of examples on the internet. I've pasted one at the bottom here, but a quick Google search will be able to give you many, many more. In terms of how we're doing social accountability, I'll come on to that in the next few slides. So those were just two examples of social accountability tools or approaches that I went into in more detail just to give you an idea of what I'm talking about. But as this table shows, there are many, many different ways of doing it. Also, these different ways are all appropriate to different contexts. As you can see from the table, it lists all the monitoring tools that can achieve social accountability on the left. And then it talks about the requirements needed for those tools to be successful. When designing an anti-corruption project for healthcare procurement, it's always important to understand these kind of contextual elements to understand which tools or approaches will be most effective. So this sort of assessment, as we see on this table, can be very useful when going into country. We can assess government cooperation required, we can assess citizen participation required, and we can assess technical complexity and skills required, for example. And then we can see if our stakeholders in the country, those that are actually implementing it, the community actors, have these necessary capacities. And then, therefore, we can decide on the best kind of monitoring tool to help them out. So in the previous few slides, we've shown the many methods through which effective social accountability mechanisms may be achieved. However, it's important to note that these approaches focus solely on the community or social side. No matter how empowered the community is, it is possible that other parts of the system, mainly government, simply refuse to allow them to be effective. This has meant that commentators such as Jonathan Fox have argued for a sandwich approach to social accountability, where reformists in government are empowered alongside social actors to really improve and systematize the accountability loop. In the Open Contracting for Health project, we've tried to achieve this through the more standard social accountability tools that I've identified earlier. So using community monitoring approaches, using community scorecard approaches, but involving government reformists along the way in those discussions. That way, it means that they're not blindsided when community groups come to them with information that could potentially be damaging, and it also means that they are more likely to have more political interest in the accountability mechanism itself. So in Uganda, TI Health and in collaboration with TI Uganda assessed the civic space and technical capacity in communities to work out what were the best approaches to social accountability. And we decided to conduct physical monitoring of health infrastructure contracts in several districts by local volunteers. This was for several reasons. One was because of the presence of strong and active communal networks. Also because infrastructure is a very visible contract. You can see when things go wrong with it, and you can go and visit sites in ways that you can't really do with things like services and consultancy work. So we found that by providing simple tools to these community volunteers, like checklists and basic training about what are substandard materials such as cement, bricks, etc., we found that it reduced discretion in this area, but also it helped identify specific weaknesses. So, for example, in several districts, we noticed that the standard of certain bricks wasn't up to scratch, which would have meant a quicker degradation rate. And we also found in one district cement that would likely have resulted in roofing collapses. So we definitely identified different inefficiency that would have resulted in a worse health infrastructure system in these districts. But as is the case in much of anti-corruption work, it's not clear if these individual inconsistencies were as a result of corruption or other influences. But what we can assume reasonably is that by building these sustainable accountability mechanisms, that corruption is reduced in the system as a whole, while definitively improving the quality of health infrastructure in the regions that we were active in. Beyond this, our project is only 3.5 years long, so through training and building the capacity of communal networks, we hope that they will continue to be able to do this beyond our support. At the same time, as I mentioned earlier, we've been trying to include governmental officials as much as possible, so that this loop between government and civil society continues past the project, and both sides of that loop are empowered to continue it. So I can go on for ages about all the good we're doing in Uganda and in the other countries, but I'm sure you'd rather actually see the people involved talk about it. So I'm going to show a video that we helped to develop in collaboration with TI Uganda about their approach to open contracting and social accountability in relation to healthcare corruption in procurement. So on to the last slide.
Hi, sorry, just for everyone, we've just had to skip that video because we accidentally played it at the start. So we're now moving on to the end of the original presentation. Thanks.
So on to the last slide. I just wanted to go over some learnings or some takeaways from this webinar. Initially, we highlighted the scale of procurement in health and why it has such an inherent risk of corruption. We've also talked about the effect this has on the health system, how it degrades the value of the resources, meaning that certain people may not get access to the care they need. We've defined open contracting as a brand for a new age approach to transparency in procurement. We've talked about how social accountability can work within the framing of open contracting. So on the one side, you have the data analysis and red flagging of procurements, which works better in a system with good data infrastructure. And on the other, you have what I called the more traditional side, which is the more social accountability side, which is about community scorecards, community monitoring, etc. We've highlighted these different approaches to social accountability, and I've given you some resources that you can look at to look at more them individually if you would like. But in general, takeaways from the Oc4h project and hopefully from this webinar have been that government and civil society working together is the best way to strengthen the accountability in a system. We've done that in Oc4h by including government officials in community dialogues in social accountability procedures. We've also learned that social accountability can help to build a sustainable resilience to corruption, even if it can't identify as well as other techniques corrupt acts, and can reduce the amount of wasted resources. So think about how the community monitoring in Uganda identified substandard materials for the building infrastructure, health infrastructure projects. Finally, context is key. The context in a particular country is key to designing your approach. So IT or data infrastructure, if it's low, then it is likely that data dashboards, data analysis, data red flagging, etc., will be less effective. That's also the case if data understanding or data competency is low amongst your stakeholders. Conversely, if civic networks are particularly strong, then it is likely that social accountability mechanisms will be more effective. We saw this in Uganda, which had particularly strong civic networks, which meant that we chose to do community monitoring instead of other approaches such as data analysis. So I hope you've enjoyed this presentation. My email is on the screen. If you want to ask me any questions, feel free. I feel that I could give a lot of resources for each of these slides, and I feel like I could go on for another hour, probably longer, but I don't really want to bore you. So if you have any more follow-ups, please contact me. But until then, thank you very much for listening, and I hope you have a great remainder of the day. Thank you.
Okay. Thank you. For the end of that, Tom is going to be speaking to you all for another hour, so you're all very lucky in that. I'm going to go through, there are some questions that have been put into the chat that I'm going to try and group and run through, and they'll be answered by either Tom, myself, or Jonathan. I'm just trying to group them slightly, so I'll do these first two together. Is there an international law that imposes government cooperation? And how can public expenditure tracking help if government publishes false reports? And linked to that, is open contracting cost effective for LMICs? Tom or John, do either of you want to answer that?
Thanks, Sean. So in terms of the international law, no, there's not. There isn't an international law as such. In terms of the kind of cost effectiveness, I think there are several elements to this. So as you may have kind of gathered from the video, and there's another question on it later, a lot of countries are kind of moving from a very traditional paper-based system of contracting to a computerized one. That is the backbone of open contracting. It's been introduced, I think, broadly in many countries by the World Bank and with support from the World Bank. And open contracting is then kind of an addition to that. I think there's a broader kind of question as well about cost effectiveness, is that how do we know what's cost effective in the health sector if we don't know what the numbers are effectively? So in order to be able to understand cost effectiveness and ultimately the kind of effectiveness of interventions on health outcomes and health improvements, we need to know what those numbers are. I think in that regard, open contracting is part of the picture. It allows you to see when a decision has been taken. So let's say, for instance, as the video kind of said, that there is a health center going to be built in a district, how cost effective that intervention has been. What it doesn't necessarily show is what the kind of how cost effective the government strategy is, for instance. So if that was tackled, if that was funded from a malaria program, and the decision had been that we open primary healthcare centers in all districts, is that most cost effective approach? Open contracting doesn't answer that. What we need to do, and what we're beginning to do in countries and thinking about, is to link that up much more strongly with other data, and governments need to do this, to start saying, okay, we've got the procurement data, we link that with budgeting data, we link that with health outcomes data, so that you've got feedback loops in place that allow you then better to say, okay, what was the result of this policy decision in terms of improving health outcomes? What did our decision, we chose to try and tackle malaria by investing in infrastructure. I realize this is probably not the way most governments do it. Was that cost effective? And you'd be able to see that then in a decrease in hopefully in malaria cases. Does that make sense? That it is part of a picture, but it is part of a bigger picture.
Yeah, so thank you, John. The next two questions are sort of broadly looking at the private sector. One is having a list of accredited vendors helpful in LMICs? And two is, are there tools / interventions aimed at engaging with suppliers to address corruption? Tom, do you want to take that one?
Sorry, can you say the first one again, please?
Is having a list of accredited vendors helpful in LMICs?
So it depends what you want to achieve. From our perspective at TI, it's very, very helpful because it helps us close the research loop between planning stage from governments and budgeting to procurement stage, giving contracts, to the implementation stage when the vendors actually take on the contracts and do the work. So having more information across that process helps us close the loop and understand trends better. So for us, yes, it's definitely useful. But there'll be lots of different use cases beyond that for different sectors and different stakeholders. It might be very useful for government, for example, in due diligence. And we're seeing that in the UK now with PPE procurement. I think John wanted to come in.
No, so go on. I say it is useful. I think there is a flip side to it, in that you've got to make sure that that accreditation process is done fairly and transparently then. That isn't then kind of weaponized by people to say, okay, only my friends can be accredited, and therefore what you have is what appears to be an open contracting process with 3 or 4 companies effectively cartelling, and those being the sole ones. So you need to make sure that accreditation process is transparent and updated regularly as well, to let new businesses into the market, because the other part of this is about market development. I mean, we've seen in Zambia where kind of smaller cooperatives have been able to bid on tenders at the local kind of district level for catering and cleaning services. They need to have the access, so that accreditation list can't be done on a 5-year basis.
What was the second question, Sean?
It's gone now. So I think you answered it in your first response. So I'll move on to the last sort of the next section of questions. There's a group of questions all broadly to do with social accountability. So I'll run through all of those together. There's 4. How do you address power imbalances between citizen groups and politicians? In many LMICs, if anyone threatens the government or someone in power, they can end up in prison or with death threats. Linked to this is how to streamline procurement when there's no civil society engagement, but only government procurement for a health system. Social accountability particularly works when there is empowerment in human rights and freedom of expression. And how does social accountability in health sector can be achieved in contexts where the health sector receives the lowest fraction of GDP? So I think broadly speaking, when there is a low amount of input into the health sector, and when there is a strong government and potentially a weaker civil society, how do we ensure that social accountability continues in projects that we're working on? Do either of you want to come in on that? Or I can give a brief overview to start with.
Go for it, Sean.
So I think that if you take some of the examples that Tom was talking about there, the way that we try to start these interventions in countries is we have, like we've explained, local chapter who knows the situation and knows the context well. They normally have government links, either at the district and at the national level. So essentially they know how to ask and increase feedback loops without creating a situation which can become hostile, where you start to get towards, like you said, prison and death threats, which is something that in the projects that we're working on has not happened or come even close to happening, because you work slowly and you work in collaboration with government rather than working completely in conflict with them. And then working with those key chapter as a key partner link, we're then able to open up into other smaller CSOs who are working in the country, either at district level. So Uganda, which you saw the video for, that's initially TI Uganda, and then followed up at, say, Lira, the district level. There's then an additional 15 CSOs working in collaboration. Once they work in collaboration and they have those links with government, they're then able to use the methodologies that we're going to probably talk about in the next section, but they can gather strong evidence base so that then when they go to talk to government officials, they're going with clear evidenced problems and actual solutions to those problems, which allows the feedback loop to start. In terms of the low input for GDP, I think this just makes social accountability and anti-corruption more important. It just means if there's a lot of GDP being put into the health system, what is being put in needs to be spent as effectively and efficiently as possible. The social accountability and anti-corruption mechanisms, especially in the procurement chain, will help that. Is there anything else that either of you two would like to add?
Just going to say, on the kind of tools and interventions and engaging with suppliers, I don't think we've got specific tools and haven't developed specific tools under the work we've been doing. But it is several things. One is we work quite a lot with private sector kind of associations, trade associations, or kind of regional associations. And then also, as Sean said, the kind of the social accountability side of it. It is about fostering that dialogue and beginning to create that kind of sense that corruption is socially unacceptable. In both the business community, but also that communities have that voice where they feel empowered, where at the local level to go back, and we've seen this in Uganda where they've kind of worked with the district health officer to flag these cases, to say, okay, this is unacceptable, that it's not corruption, but it's shoddy workmanship. We feel empowered to go back and get kind of call in the contractor to account. And similarly, what we've also seen is that many businesses are actually willing to compete on competitiveness, rather than on nepotism, and the smart businesses actually see the kind of advantage in this, that if you can be a competitive business in the long run, it's beneficial for your business and it allows you to enter more markets, rather than basing your kind of business around a nepotism, clientelism type approach.
Okay, so there's actually been a few more questions being put up whilst we've been discussing these, so I'll just, instead of grouping them, run through them quickly. The first two, Tom, do you want to we forgot to define corruption, and then in close relationship is with conflict of interest and accountability, is there one approach to capture good governance as a whole?
Okay, so the first question, there's many different definitions to corruption, and often it's culturally contextualized. But at TI we have quite a broad one, which is the abuse of entrusted power for private gain. So that's the test we use to find if a particular act is corrupt or if it isn't. What was the second question, Sean? Sorry.
Transparency is in close relation with conflict of interest and accountability. So is there one approach to capture good governance as a whole?
It depends what you mean by approach. Transparency as an approach can capture all of that information, and there's different ways in which you can do that. If you're interested, there isn't one approach that works everywhere, but there are many different approaches that you can choose from to work in every context. So it depends on the context that you're working in, but if you're interested to know more about the different types of approaches, our email is at the end of this presentation. You can just ask a bit more specifically.
Yeah. Then we have another question, which is, do you think that some actors may find ways to game open contracting? We find that initially initiatives work, and then some actors find ways to bypass the rules. Do we know the sustainable is the effect? How sustainable the effect is of open contracting?
So open contracting is it's a broad tent term for a lot of different approaches to procurement. What I would suggest in terms of sustainability is that there be many different types of approaches, including data analysis, social accountability, and that reduces the risk that there will be people gaming the system, but there will always be a risk. Transparency isn't the golden bullet for this sort of thing. It's systems building, accountability systems building, and there's always going to be a risk that someone will find out a way of gaming that system.
Okay, there's two last questions, but one is, how do we get governments to buy into the concept of computerized procurement? And I think that we're going to come on to that in the next section. And the last question is very specifically about our work in Nepal. So what I would suggest for there is, as Tom has just said, our email addresses will be on the end of this presentation. And if you'd like to talk further about the work specifically in Nepal, rather than more broadly, you can send an email and we'll happily have a follow-up conversation with you instead of going into that level of detail right now. As we have been on for almost an hour. I think that if we just have, we're going to give everyone a 5-minute break. So until, I mean, it's 9 o'clock UK time, until 0 o'clock, wherever it is that you are. And then we'll come back and start the final section, or the third section of this session. Thank you all very much for your questions, and we will talk to you again in 5 minutes. Okay, thank you very much. I hope everyone has managed to grab a quick cup of coffee and get back. So as I mentioned just before we broke, we're now going to carry on, and this will be a slightly more interactive and the more focused on the skill building part. Tom will be taking you through this. So Tom, if you're ready.
Yep. Hello, everyone. As introduced earlier, my name is Tom Wright, and I'm the researcher for the Transparency International Global Health Initiative. And I've been, mostly over the last 3 years, I've been working quite a lot on procurement data and how it can be utilized in LMIC contexts, in the context of health, with the overall aim of improving health outcomes. So this first slide is going to be about linking what we're doing to the overall problems, which is the inefficiency in health financing, both at the public level, so at the national level. In general, the WHO has pointed out that global healthcare financing, about 20 to 40%, does little to improve people's lives per year globally. So that's a huge amount of money that obviously doesn't go into effective projects or public projects. 6 of the 10 reasons for the proposed 6 of the 10 reasons proposed by the WHO are directly related or indirectly related to procurement systems. So you can see how procurement is important in the in creating that 20 to 40% figure. This is combined with the fact that 7% of global healthcare expenditure is lost to corruption. This is part of that 20 to 40% figure, but is worth about $500 billion a year. It's therefore very likely that in a theoretical situation in where there was no corruption in a procurement system, more than the $370 billion per year needed per year to achieve SDG 3 would be saved. So, okay, I think next slide. Okay, so given the relationship between procurement inefficiency, including corruption, and worsened health outcomes, the utility of monitoring in reducing these inefficiencies becomes obvious. It can help uncover patterns of inefficiency and in the areas of competition and in corruption, etc. So our previous pre-recorded video talked about mostly civil and communal side of monitoring of procurements in health. So including social accountability exercises such as scorecards or community monitoring. This one will go more into a bit more detail about the data side of procurement monitoring. So as John mentioned previously in the this webinar, many governments have been moving to e-governmental procurement systems, which record data on and information points on different procurements with more or less degrees of success. So can we go to the next slide, please? Okay, so computerized data, while perhaps needing a different skill set, enables quick and efficient access to information on procurement systems if set up correctly. It's quick and efficient because procuring officers and entities can access this information for many procurements simultaneously, reducing the time needed to monitor procurement. So that's from the governmental perspective. In terms of if the data is made transparent, it can help if civil societies have the capacity to analyze the data very effectively, it can help hold government to account in the area of health procurement and spend. And I'll go into that a bit now. So, yep, next slide, please. Computerized procurement data, however, is not a standalone solution. It requires a different set of skills and is limited in the insights it can bring. For example, a community monitor that going through the process that was explained in the last pre-recorded presentation may see in more detail the implementation of a health infrastructure procurement if they visit the site itself? Well, computerized data can only provide selected snapshots. In a perfect system, and this goes back to one of the questions that I answered about 5 minutes ago, in a perfect system, therefore, stakeholders in the monitoring process will use data analysis to supplement existing expert knowledge as well as different and perhaps physical forms of monitoring. So it's using multiple different methods of monitoring to try and really create a robust accountability loop in healthcare procurement and thereby reduce inefficiencies caused by corruption or not by corruption, and thereby improve the allocation of resources. The next one. So there are a few ways we can use health procurement data to try and provide this snapshot, and I'll go into what they are, and then I'll go into the process through which they can be used. The first is an indicator. I'm sure everyone knows what an indicator is, but in terms of health procurement, it provides a snapshot of an entire sample or perhaps an entire procurement system at scale. So you can see many different procurements at once within a particular indicator. They can provide quick and valuable insights to a system, which can be very useful for the purposes of advocacy or by governmental monitoring, and can be in the, for example, form of graphs, visualizations, or statistics. Okay, so indicator visualizations provide a snapshot of a particular element in the procurement system. This indicator, using an open data standard called the Open Contracting Data Standards, it uses data of OCDS, the Open Contracting Data Standard data. It's actually from the UK government at the moment. This comes directly from their online procurement system. And this indicator is an example of how you can check cost efficiency side of procurement. So this indicator may not provide any insights into corruption risk, but it does provide quite an easy to understand snapshot analysis of a particular procurement system, in this case, the UK. So as you can see, this indicator shows it's supposed to indicate the cost effectiveness of a particular element of the procurement system. In this case, the blue bars are representing the total tendered amount for procurements in health in the UK. So, sorry, I just need to zoom in a little bit. So in 2017, it was about 15 billion that the UK tendered for health procurements. So that's how much, what value that they have planned for in the health system. In the same year, using the same procurements, they spent over 35 billion UK pounds, Great British GP, sorry. And it seemed, so that is more than double the amount that was tendered. So that means that the UK government has essentially spent way more than they planned to spend, which in itself can give an insight into the system. So for example, it may indicate that the planning stage or the budgeting stage of the procurement process in health is inefficient because it's not fully understanding how much is going to be cost actually be spent in the system, which for example, a procuring officer in a particular entity or in a particular hospital or anything like that could see this and then identify areas for further research or for further monitoring. Essentially what this does is identify areas of risk. Next. So another way in which we can use procurement data is through red flags. And this is often used in anti-corruption as a red flag is a warning or indicator suggesting that there is a potential problem or threat. So in corruption studies, it could be that a red flag could represent a vulnerability to collusion or bid rigging, for example. Red flags can be used to monitor any part of a system from, any part of the system from a specific procurement to an entire system. So there can be red flags in a particular procurement, one procurement process. It could say that there could be a red flag in that the tender period was too short for this particular contract, or it can be for the entire system. So in the entire system, there may be a trend in that the tendering period is always too short, which would therefore represent a red flag in the tendering period. Can we go to the next slide, please? So this is an example of a red flag analysis. This is an entire system. So this is all of procurements in the UK system in health. And essentially, sorry, this is in South Africa, not in the UK. Essentially, we say that the red flag, the norm is that an open or competitive tender should have more than a single bid. However, we say that it is a red flag if a tender that is open has only a single bid. And this is what this graph is showing at scale. So the black element of the graph is showing how many out of the total amount of procurement, total amount of open procurement, sorry, how many only featured a single bidder. So in 2016, it was just over 2,000 flagged tenders to 3,500 total tenders. That in itself is quite a high percentage of contracts that are only receiving a single bidder, which means that procuring entities may want to look at why that is the case and start drilling down on what are the situations or the markets in which that cause single bidders only on open awards, open tenders. While civil society organizations may want to be, such as TI, if you're looking from an anti-corruption perspective, may want to be looking at this to work out where there may be elements of collusion, lots of informal connections between suppliers and procuring entities, etc. We go on to the next slide, please. So red flags, they can be used in different ways. They can be used in different ways to conduct research. And I hinted at this in the last slide, but essentially you can start with an issue. So rather than it's all about which entity of research that you start with. So you can start with a particular procuring entity. You can start with an entire system. You can even start with a particular item. So in the context of COVID, PPE has become a very important research entity in the area of procurement, personal protective equipment. So that when deciding to do a red flag analysis, it's very important for whoever is conducting this research to pick an issue that is politically salient and or useful to them. If you don't really know the context or you're not sure what you're looking for, it's always okay to start with common red flags. So a common red flag would be tender period being too short, for example. And looking at that at an entire system and investigating different areas in which you can look at it, and then investigating different red flags and see what pops up in your system, in your data. So which areas of the data have the most red flags. And therefore, once you have an idea of the data more generally, you can start to choose more apt research questions and entities. So as I said in the last bullet point, how do you choose where to start? Essentially, if you have a strong theory that is embedded into your project goals, for example, there has been news articles on a particular supplier, then you use number one. So the research entity or the entity you're concentrating your research on in this example would be the particular supplier. If you're not sure, use number two. This is a very broad overview. There are many different ways you can do it, but in general, they fall under these two categories. Okay, yeah, next slide. So visualizations provide a snapshot of a particular element of the procurement system, depending on which entity you're doing your research on or monitoring. Sorry, wrong notes. This slide will go into a bit more detail about the process of how to translate and break this kind of research, break down this kind of research from a governmental perspective. So and thereby enable the identification of trends in inefficiency in health spend resource allocation, in this case in the procurement system. In a hypothetical situation, the procuring officer or similar is given a group of visualizations and asked to identify inefficiency, then broadly the process will be the same as identified on this slide. But it's very important that whoever is doing this research, whether governmental entity, person, or CSO, that they draw on knowledge from their context, i.e. the knowledge of the procurement process, so how the procurement process works in a particular country, and what is useful for them in that country. So that's really the idea of how to get useful analysis and red flags. We're going to go into a bit more detail about this in the next slide. So this is an example of how indicators are being used in the health system. At the end, we can link you to this website. This is the kind of sorry, this is general procurement data, not just health, but yeah, this is the kind of insight that data can give you if constructed well, and we found it very useful. So in the first graph on the left, you see the average score of administrative capacities of indicators over time. Obviously, again, it's going down. There's a trend there in that the administrative capacity in this particular country, because the unit of analysis is a country, is going down. And then on the right, it breaks it down by sector. So you may be able to see why this might be useful for government and for civil society to understand the procurement system in detail. Next slide, please. However, we are talking mostly about Lmic'S, and a lot of our work is in countries with lack of data capacity or data infrastructure. So while the previous example was a bit more advanced, it used more complex data analysis and methodologies to assess administrative capacity over time. This graph shows a less detailed, less analytical use of procurement health data. This one comes from Zambia, and it shows the breakdown of particular, breakdown of the entire health budget in Zambia for a particular year to the most commonly awarded suppliers. So, for example, the blue one, which is Josiel General Dealers, is about 18% of all of the health expenditure in this particular entity. Why is that useful for governments? It could be useful to understand the market a bit better, who they need to consult, who are the important players, for example. For civil society, it could, if there is a huge percentage going to a particular supplier, it could represent state capture. Very unlikely in this situation, but it could represent too much influence of particular companies over a particular procuring entity. So next slide, please. So we're just going to take 5 more minutes, or I think Sean is going to paste this into the chat for me. But essentially, I'm going to show you a couple of visualizations that we have constructed for the Open Contracting for Health Open Contracting for Health project. Again, we'll give you the links to the data at the end. Basically, just get your opinions on it and what you think it shows and how you think it's useful, and then we'll go through it. Sean will help me go through it. These are just examples of what you can input into the chat, but you feel free to add in anything else that you want. So the first visualization is the next slide. So I hope you can read that. But using the prompts from the previous slide, which should now be in chat, do you want to input into chat your feedback? And this will be until 25 past. So I'll let you do that. Sean, just let me know when lots of people are.
Just so to keep it clear, there's the Q&A, which we were using before, but you can see below that there is a discussion forum. So just for this task, we'll just use the discussion forum, and I've posted the questions that were just on Tom's slide in that. So you can either go through, and I think you can reply to the specific questions if you have a point, or you can just enter your thoughts onto that discussion forum, and we'll then come back to it in a minute. Okay, so we've got a few comments onto the discussion board in relation to these particular visualizations. I'll just run through them and then Tom can respond and carry on. The first is there a way to indicate data quality for each indicator, in brackets reliability / validity? For some, maybe easier to collect data. Perhaps each indicator can be given a weighting.
Was that more than one point, Sean? Or was
that's one quite long question.
Okay. So in terms of how to assess data quality, it's very difficult, yeah. And I think I love this question. It's a great question. I mentioned earlier that we advocate and try to use, and the visualization in the presentation right now is using this format, but the Open Contracting Data Standard format, which provides lots of tools to verify and to format data in a way that enhances quality. So that's how you would assess data quality, using these predefined tools that aren't specific just to health, for any procurement. In terms of enhancing quality, that comes down to, for us at least, an advocacy question. Working out what are the most viable use cases on the ground, what would be the most useful information and indicators, weighting in that way, what would be the most useful ones, then doing small samples and running analysis on that indicator to assess to what extent to assess data completeness, quality, and usefulness, essentially. That's the overall process, how we would do it. If there was a low data quality, usefulness, completeness, then we'd use that combined with our assessment of what is useful on the ground to target key stakeholders such as governmental institutions, such as big CSOs, to try and influence try and raise awareness in the channels of influence that can make change. Yeah.
Okay, thank you. The next point is that graphs are a useful starting point and monitoring tools, but then effective engagement between key stakeholders is important to take forward. This would include building relationships and ensuring buy-in. That's absolutely correct, and something that we've been discussing, and we'll continue to discuss this. This is a central component, but it is still just a tool in order to help build those processes. Understanding this sort of data will mean it's easier to build those relationships with key government stakeholders to have the conversations about procurement. And then the last point is useful to measure integrity of the procurement cycle by assigning sources for the various critical steps. So would it be useful to assign scores for the various critical steps?
So if by that you're meaning, if you're talking about the current visualization here, that's kind of what it does do. It doesn't break it down into the 5 contracting processes as we see it, which starts with a tender, award, contract, tender, awards, contract. No, sorry, planning, tender, awards, contract, implementation. Those are the 5 steps as we see the procurement process. You can, and it's very useful to break it down in that context, especially when it comes to research, and also because different governmental entities and different CSOs are more involved in different stages of the contracting process. We, for example, have seen the implementation stage not be monitored by procurement officers and instead only the first 4 stages. So yeah, it's very useful to break it down into those different stages and score them individually. This visualization does it in a slightly more specific way, in that it takes key elements within those stages and assesses them. So one of the worst performing indicators in this one is single bidder contract is scored very low. So that relates to the tendering and award stage of the procurement process, because there was only one bidder. Yeah, essentially.
Okay, and one person has said that it might have been more helpful to do this in a poll. I'm sorry that it wasn't done like that. Unfortunately, we couldn't do polls or a different method in the current HSG system, and we wanted to keep everything in one place instead of having to get people to go back and forth between different sites and users. So hopefully it's still quite clear. Do you want to carry on, Tom?
Is there any more points?
Nope.
Okay. So I was going to do a similar exercise for a different procurement, a different visualization. If we can go to the next slide. Maybe I'll change the format of this a little bit. I hope that you can read that because it's quite small. But essentially what this visualization is doing is showing the average amount of bids per procuring entity. And we operate under the assumption that the more bids, the more efficient, well, to some extent, within reason, the more bids, the more efficient a particular procurement process would be, and therefore the best allocation of health resources. So it might be a bit too small to see, but essentially in this, we can see that there are particular best performers, and there are definitely ways in which this graph can be improved, and there are different insights. Rather than going to the chat, I'll just give an overview quickly. But essentially from this, you can see that the Electoral Commission of Zambia, so this is from Zambia, relies heavily on limited procurement processes, so only contracting within a group of suppliers or vendors, and very often doesn't use open procurement processes. While the Road Development Agency often has 12 bids, that's on average 12 bids for each procurement, and often rely on open procurement processes. So from this, you can kind of see who is performing best and worst if you take the assumption that open tendering is better and that more bidders are better. So, however, as is always the case with visualizations, accessibility is always an issue. And you may have been experiencing that now by not being able to read the titles of the procuring entities. That is a very valid criticism of different visualizations. They're supposed to be usable and user-friendly. Another issue which was highlighted earlier is that this analysis actually is only on about 400 procurements for an entire country. So the sample size is particularly poor when you compare it to the amount spent. And that is an issue that we've been finding a lot in LMIC countries, and basically the completeness of data isn't there for us to get good conclusions and good research. So when this situation comes about, what we tend to do is merge our data analysis with more social accountability and advocacy related approaches. Yep, next slide. Sorry, 1 second. Okay, so policy recommendations. This is from a civil society perspective, using data to translate them into policy recommendations. So policy recommendations are essentially the bridge for civil society organizations from research into advocacy. That they provide simple, concise, essentially summaries of the outputs of the research, and are very important for advocacy processes, because different CSOs can provide quick oversights of the research to particular departments which may not have the time to go over all of the research. So I'm sure that almost everyone will have used policy recommendations at a particular time in their occupational in their career, but essentially the measure of a good policy recommendation is conciseness, readability, and accuracy. So data by its nature, because of its quantitative nature, procurement health data, it lends itself to these three measures of success. It means that you can pull out key statistics such as amount spent, number of red flags, number of contracts by to a particular supplier, and put them into or next to your policy recommendations to really drive home the point. So yes, so essentially what one should be doing when translating this kind of research is, what we found most useful is translating these visualizations into particular policy recommendations. And we can give some examples in the Q&A afterwards. But yeah, I think that's, next slide. Okay, yeah. So these are some additional resources you can use. The OC Hub has a dashboard where you can look at the different visualizations in the health sector, specifically in the United Kingdom, Zambia, South Africa, Kenya, Uganda, and Nepal. Please feel free to log on and just open it and have a look through. The first one is our website, and the third one is a collation of different anti-corruption projects that are happening around the world in health. And like as promised, our email addresses are at the bottom there if you want any more detail. Next slide. Sean, do you want to lead in?
Okay, thank you very much, Tom. So we've got 3 questions at the moment, and then if people have anything else that they'd like to add as we're starting to answer these, please feel free to add. The first question is, all eyes are on government and corruption, and often outsourcing the procurement process to private companies is the preferred solution. The challenge is that outsourced private companies are not scrutinized in the same way. My question is whether any evidence exists regarding that mechanisms of procurement as a means to reduce procurement corruption.
Okay, I'll start with this. 1 sec. So yeah, it's very true that procurement systems in health, especially medical, like medicines, etc., being outsourced to companies with the narrative that it will reduce corruption and improve competition, or efficiency at least. So this has happened in Ukraine, which passed legislation in 2015, which mandates that the procurement of all pharmaceuticals is outsourced to a pool of 6 non-profit international organizations: UNDP, UNICEF, Crown Agents, Partnership for Supply Chain Management, Global Drug Facility, and the IDA Foundation. The former 3 purchased on behalf of the Ukrainian government in 2016. The latter 3, while not contracted in Ukraine, purchased medicine on behalf of other governments around the world. So that's just an example of what we think that you're referring to. The transparency and thereby the transparency is a proxy indicator for corruption risk. The transparency of these initiatives is varied and don't fit neatly into the definition of open contracting. They achieve integrity by securing participation of actors from outside government. They are particularly good at that. But the corruption vulnerability varies from country to country. It's not to say that it's a silver bullet and it won't automatically reduce corruption. Yeah, but there are examples where it has. For example, in Ukraine, as part of a broader process of reform, not necessarily because just of this, the health sector has been upheld as a bastion of anti-corruptive procurement systems, essentially. John, I think you wanted to add to this.
Yeah, can I just add on this? And I don't have any specific evidence, but so kind of if you think about the normal rationale, the conventional rationale for outsourcing, is to improve efficiencies and to reduce yours, and I say you as the Ministry of Health, or government's kind of financial risk in this. And I think the devil is very much in the detail here. What in an ideal world you should be doing when you outsource is you're outsourcing, applying the same standards that you would do as the Ministry of Health. So that contract with the outsourced entity should include, if there is national requirement, should include the requirement to conduct tenders in a fair and transparent manner, and to implement open contracting procedures and potentially feed into the national database on that. But you need to get the contracts right. And what we often see, I mean, here in the UK, we outsource a lot, and those of you who follow kind of the British news have kind of seen that we've outsourced track and trace, our COVID response track and trace system to a private entity, Serco. It's not been performing very well, not due to corruption, but due to other issues. What tends to happen, and this is one criticism of the UK, is that the government's kind of capacity then, because there's been so much outsourcing done, government's own capacity to actually monitor these outsourcing contracts has been hollowed out. So what you've got basically are outsourcing companies that run things, but the government has no capacity to actually effectively kind of follow up and implement on them. And that's, I would say, is one of the dangers if you get out too far down the outsourcing route, is that you effectively lose kind of that control, both in terms of monitoring for transparency and anti-corruption, but also more broadly in the government's ability to deliver its health services.
Okay, thank you both. The next question is, I would be interested to hear about your experiences you've had in implementing such an approach with local health authorities, district or regional level, how such initiatives can be integrated into the existing system rather than adding parallel system to ensure long-term effect. So I can start on this. Again, if you look at the example of Lira in Uganda, a lot of the work that we do works at that district level. I think in a lot of ways, it's easier to provide sustainable impact because you can get in the room with those district health officials, you can have those conversations. So in Lira, the work that TR Uganda have done with the local CSOs in advocating for more open contracting has resulted in 100% of all health procurement within that district being published to the current EGP. And once you can then start to show the impact that that is having, it's then almost, you've achieved positive result at that local level, and you've almost given yourself an advocacy point to then take that to the national government, where it's sometimes harder to create those relationships. In terms of creating a parallel system, you're right, there is a few cases in Kenya, and I can't remember the name of the county, but I can send it to you if you want to send a follow-up email, where they've created a specific procurement portal for that county and have found that it's only effective when it immediately duplicates the data to the national EGP, because it's legal requirement for people to upload data to the national procurement system. So if they're doing it on their local system, and it doesn't immediately go over. If they have to do it on 2, it won't work. So yeah, it only works if it's easy to duplicate, basically. Hope that answers that question. Next question is, we've been looking at crowdsourcing as an opportunity to get real-time data. What is your view on this? Tom or John, do you have a view on that?
It depends what you mean by crowdsourcing real-time data. Whoever asked that, can you clarify a little bit in the chat? And I think there's another question that you missed, John. Sean, can I answer that one while we wait?
Yeah, so the next question is, what is the role of technology platforms in reducing corruption? And does open contracting promote the use of technology?
So I'll take the second one first, which is, does open contracting promote the use of technology? So a big element, and perhaps the element that really started this movement, is data and open contracting data. So open contracting does include social accountability and more traditional forms of procurement transparency, but it has a big influence on solving global issues and using modern techniques to do that. And the modern techniques are mostly data. Data is essentially the life source for all technology. If you're creating apps, then you need data. If you're creating EGPs, or if you're creating dashboards. So in terms of, does it promote use of technology? The easiest way to say this is yes, but also examples include dashboards like the ones that I was showing earlier, but also things like it can be used within the context of social accountability. For example, the most accessible way to access the internet in lots of countries is through mobile phone data. One could theoretically, and this has happened, set up procurement apps that feed data to community monitors that are going out to particular health infrastructure projects such as hospitals. They feed data into this app, which shows them what kind of materials should be present in this construction site. What should you be looking out for? What does the contract say about what is there? What is the rest of the relevant information? And it would be fed using the open contracting data standards into this app so that community monitors can more successfully monitor a particular infrastructure project. That's just one example. There are many, many different examples. If you're interested in the role of open contracting data in technology, I advise you to go on the Open Contracting Partnership website, which has a good resources section, which has many different data tools, different visualization suites, different ways of accessing data. I would say that technology is limited in the use of open contracting by the capacity of the user, and often Excel, CSV files are the best way to use technology for open contracting analysis, and it's very simple. What are the role of technology platforms in reducing corruption? I mean, technology platforms are a hugely broad subject. I think in terms for the answer to this question, I'll use e-government procurement portals as an example rather than anything else. But it plays a very important role in reducing corruption, but it's not, again, it's not a silver bullet. There are so many different elements that relate to this, like the functionality of a system. Is it always up and running? Is it always publishing? Is there bugs? Is there things like, is there, will it only run on particular web browsers? This sort of thing. Even if you assume that that technology is a very good way of reducing corruption, these sort of things reduce its utility, and to the point where if it becomes unusable, its effect on reducing corruption becomes minuscule. But there have been, as far as we can tell, very good examples of e-procurement systems and citizen monitoring platforms in Ukraine, for example, and mostly in Latin America and in certain places in sub-Saharan Africa, where I can send the specific research. We've produced a document on it. I can't remember the exact statistics off the top of my head, but if you want to Google making the case for open contracting in healthcare, that's a report that we did on this kind of subject. Essentially there are lots of different factors that stop or can enhance technology's role in anti-corruption. A lot of people think it's a silver bullet. It's not. It can be corrupted in itself, especially if you have situations where understanding of a particular system is concentrated around a few groups of elite people, potentially. That can mean that the system serves to systematize corruption rather than reduce it. But if it's set up in a way where where community has oversight, where it's usable, where it's accessible, which is really important, then there has been many examples where it has been seen to drastically reduce corruption. That was all about e-procurement platforms and perhaps publishing platforms. In terms of other technology platforms outside of procurement, you can have different, not necessarily, sorry, in terms of other technology platforms in procurement and outside of procurement. In procurement, you can have different apps that help with community monitoring or setting up scorecards, etc., which really enhance the process if they're used well. Well, outside of procurement, you can have whistleblowing apps set up to anonymize data, but also allow you to record when you've been asked for a bribe by a doctor, etc. So it really depends on how it's implemented and the context through which it's implemented. So yeah, no easy answer on that one, I'm sorry.
Thank you. So the next question is, the marketing of healthcare products tends to influence procurement, and how ethical is that?
Thanks. I think that's a really interesting question. And as I said earlier, open contracting is part of the solution. What it's doing is coming in effectively at the point where you've said, we've taken that decision, we're going to buy, if we're talking about healthcare procurement, this drugs or this equipment, and we want to do that in a transparent manner. It doesn't answer the question of it doesn't necessarily answer the question of are we buying the right thing to tackle, to address the need. And I think what as I said earlier is what countries need to do is ensure it's in a big part of a bigger process, a bigger feedback loop. And there needs to also be more transparency around that decision-making process, as well as stronger regulation as well. Where you've got companies that are able to influence, there needs to be stronger regulation on that. And I suspect this is basically another session, a very interesting topic, but is not kind of covered by open contracting as such. It's about countries' kind of capacity, the policy and legislation they've got in place to prevent that, and also then the kind of transparency around those lobbying efforts and others to try and redress that.
Okay, thank you. The next question is, does your social accountability process include civil society representation on tender committees? So one of the things that is important to point out, like when Tom went through his presentation on social accountability and laid out several different methodologies for that, the way that we've set up the project is that it's done slightly differently in all scenarios, because it's not very sustainable or very helpful for us to do the full design and tell people how exactly to do this process, because it won't work the same in Nepal as it does in Kenya, for example. So there's been a lot of, or not a lot, but small differences from context to context. So where there are tender committees, I think it's in Zambia that they do have civil society representation now through the social accountability of this project. on those committees, but in other places there isn't sort of a specific tendering committee. There's just procurement officers who will do the whole process, and the civil society will be interacting with those procurement officers as a means to create feedback loops in regards to the procurement process. So I hope that makes sense. If we just go back to the previous question that we were discussing, and there's been some clarification. So the original question was, we have been looking at crowdsourcing as an opportunity to get real-time data. What is your view on this? And then as a clarification, crowdsourcing, those with roles in the open contracting process, participants/observers, being able to send relevant information. This can be analysed qualitatively. Tom, do you want to take that one?
Yeah, sure. Yeah, that makes sense. Apologies. So it depends. Send relevant information. This goes back to the more social accountability side of potentially community monitoring. So sorry, let me. Okay. So yeah. So our view, we've been doing it on a very small scale, but we have been doing it. My personal view is that it can work very well if the right systems are set up. So in terms of how this might work is through an app, for example, or through just a laptop or anything really, is going a community monitor going to an infrastructure project and writing up particular insights, which can then be sent somewhere else and then analyzed en masse. It can be a really useful endeavor if the goals that you want from this research are clear and whether they are effective. So whether they're contextually ingrained, for example. We do it quite a lot on a quantitative level in terms of getting, we're working currently on a project monitoring COVID procurements across the globe. And we've been asking different organizations to send us data on these procurements, which we're then putting into a global tool, a global monitoring tool, which is similar to a dashboard. It's a dashboard/monitoring tool, so people can use it to go and verify information on the ground or can use it for academic research. So we found that process very useful because it means that the data is, it has been collected locally, so it is relevant and we can trust its integrity a bit more. And in general, in the open contracting community, that approach with quantitative data has proved really important. We haven't done it as much with qualitative data though. I hope that answers the question.
Thank you for that, Tom. So we're now going to be drawing the session to a close. There's no more questions currently on this dashboard. From what I understand, the site that you've been posting questions on will be open for the duration of the week. So if you have any other questions, you can feel free to post them there and we'll revisit it and try to answer you directly. Additionally, as we've said throughout, feel free to go back, find our email addresses and get in touch with any one of us. We can set up a direct call or we can just try to answer you via email. So, I mean, as it says here, back to agenda and timeline to see what sessions you have through the rest of the day. I'd like to quickly thank everyone at HSR for helping set this up and thank colleagues Tom and John for helping give this presentation. And thank everyone for their participation. So that's all I hope to hear from some of you soon. Thank you very much.
Thank you.
Thank you.